Hello and welcome to episode 5 of Medical Today. I'm Jared Ratnam and you are with us on the Brahma News channel. Of course, on Medical Today or season 2 of Medical Today, we focus quite a bit on aging and well-being. Now today, we're going to go a little further to understand aging and elderly care management. Now, the word elderly is very loosely used in this country, and we're also going to be finding out about using that word and how that may hurt sensibilities within the country. Joining us is our usual suspect, Dr. Navindra Nageswaran, Group Managing Director of Global Doctors, and with him is lovely Suhaila Mohamed Kassim, the Director of Nursing from the Global Doctors Group. Thank you very much for joining us. It's a pleasure to have both of you all here. The usual suspect is back. Yes. Next we're going to call you Kevin Spacey. But that aside, today we're talking about aging and elderly care management. Now, how can we care, or I mean, my first question is about caring for the elderly at home. How can we start thinking of that and working towards something like this? Maybe Dr. Navin can start with this.
Yeah, basically you need a lot of commitment from the family when you're taking care of elderly at home. You have to make the environment very secure and safe, because it's like having children. We have, you go to IKEA, you buy all those things that no sharp corners, but for elderly, you need to do the same thing. You got to think of all that. And lastly, you need a lot of networking. You need possibly telephones, mobile phones in different places, so they don't have to rush to a phone. So simple stuff that can change the environment, and that's how you normally take care of them.
Your speciality is primary health care.
Yes.
And you've seen a lot of this happen. Now, in the landscape of changing things in Malaysia, when you talk about elderly management at home, do we see leaps and bounds in Malaysia?
It again comes to what we discussed earlier on the infrastructure and design of the homes that could be feasible, and then easy accessibility, because mobility is a big problem. Secondly, I think, to answer the question directly, primary care has to play a bigger role in preventive. It's like community. I think the United Nations has started something called I Hope, which is actually trying to look at the intrinsic factors of growing old. And that is something that Malaysia should look at on the primary care level.
Right. Another very interesting point that is here is caregiving help. Now, training for caregiving help in Malaysia, do we have enough expertise when it comes to training caregiving help? Because caregiving is not as simple as ABC as we think it is.
Yes.
Right? No, most of us employ maids from other countries, or I don't like to use the word maid, but help from other countries, and they come in to mask as home caregiving help, but they're not trained. So is there a problem with that?
Yes, I think there is a big problem with that, and that has to be addressed. See, maids can do certain jobs, but maids can't do everything, but you got to guide them. I think primary care doctors can actually help. I had a doctor who needed someone to just put eye drops, and the ophthalmologist actually taught the maid how to put the eye drops for them correctly and timingly, because in glaucoma you need to put the eye drops in timely manner so that you don't increase the eye pressure. That's the simple thing. You need a little bit of training, and it has to be done from the doctor and also the community at large.
Now, coming into you, Suhaila, how do you take care of elderly parents? Because this is, of course, your area of speciality.
Correct.
Yeah, let's take a look at now, what would you do? What do you see when you see help for the elderly?
I think basically what is most important thing for you to take care of your elderly parents at home, you have to care you have to give them lots of love. You have to have that compassion. You have to treat them with dignity, with respect, and of course with lots of patience with them. Because you must know they are not parents that who you know before. With the aging process that they are going through and all, everything has changed. They are who they become in front of you. So you have to address that kind of processes that going on. Caring of aging parents in today's busy society is not easy. It can be like very, very challenging, and it's very demanding. Furthermore, we are the sandwich generation.
Right.
Have you heard of sandwich generation?
No, I don't. Please walk me through this. I'm keeping very quiet here and trying to act intelligent.
There's a type of sandwich generation though. So anyway, we're going to talk about sandwich. Sandwich generation is like, you know, we're taking care of our parents. At the same time, we're taking care of our kids as well. So you have to give them support financially and also emotionally.
Right.
Okay, rule number 1 to take care of them, don't be your parents' parent. Okay, so you have to understand the role has reversed now. You must understand, of course, you have to structure a proper schedule for them. You know, you have to have environmental preparedness in your home. That means to make sure, you know, like what Dr. Navin was saying earlier on, you have to make sure all the flooring is all right, the toilet is okay, you know, the lighting, the furnitures, how you arrange the furnitures is very important. Because as they age, as you know, the vision is not as sharp as before, you know. And then the lighting, they might see, you need a bright light so that they know where's the look and corner.
I'd like to go back to one point you're talking about, you know, and it's resonating with me. I'm sure it resonates with a lot of us. Don't be your parents' parent.
Correct.
Would you like to comment on that?
Yes, it's like,
because,
you know,
yeah, most of us kind of do that without knowing.
Yes, correct. The problem is you cannot, rightly said, you cannot reschedule them. It's like if they wake up at 5 o'clock in the morning and they do this, just follow the schedule. And you take them on a holiday, follow their schedule. It is not like how they would have allowed us and they put schedules for us. But when it comes to them, you have to change. You have to follow their schedule. Because when you don't follow their schedule, it immediately leads into depression, unhappiness, because they have already passed through that age where we would listen to them. So that's
right.
basically.
Another interesting thing is a lot of people now say that we have to teach our parents how to use modern technology, and I think that is so important, at least using a mobile phone to be able to call us. And what are your thoughts on this?
I think it's very important because to stay connected, because everything when come to elderly, become to senior citizen and things like that, to stay connected is very important. You know, like by them staying in one family, she must have like 6 other children. You have extended family and all. And then because we've been very busy, we don't have time to go and do visiting every time. And so when they have the smartphone, like my mom, I taught her she can do Skype, she can do WhatsApp call, video call and everything, which she gets very closer to her family, extended family, like her cousins, her sisters, brothers and all.
If they're well into their 80s, Dr. Navin, you know, do you still endeavor in helping them learn or embrace technology?
Yes, I would definitely agree. It has to be embraced. One thing Steve Jobs did correctly, he took the grandchildren all the way to the grandparents. He connected them, because that's like from WhatsApp to YouTube to all the technologies. Same thing like her mother, my mother too, enjoys the WhatsApp. They communicate faster than anyone else. So starting is very difficult. Getting them to change into this technology culture is extremely difficult. But once you get them onto it, it's mind stimulating. They have something to do, something to look forward. Like watching TV, you can watch TV for a while, but eventually you want to do something else.
They need to talk to someone. They need that human touch, you know. And knowing our mothers, you know, they like to gossip. Of course, they have to like update, you know. It's like
there's a lovely Malay word for it these days. It's called Membawang.
Yes, of course.
Fantastic.
So it's like, okay, I have something to tell. I must tell now, you know. I cannot like just voice call because there's no satisfaction. I must see their face, you know, like video call. You know, that's what they do.
And then get WhatsApp messages and then re-forward it to someone else and forward it around.
Right. And because most of your care or the work you do works generally around the people who are senior citizens. Now, we use words like senior citizens, the elderly. You know, I'm closing in on 50, and if people call me uncle, it kind of hurts, you know. Yeah,
I'm sure
but
that hurts.
how do they accept these terms when we say elderly?
Well, it's very subjective question. Of course, you know, as all of us age, we would like to age gracefully.
Right.
Okay, and then this is like something ageism. So it's like, it's not nice to be like called like uncle, auntie. You always can call like, oh, can I help you, sir? What I can do? Hi, ma'am, can I help you? I think that is a better way of approaching them rather than like, makcik, you know, like always like,
Right.
it's like more. It's
Malaysia
more,
has
yeah.
that thing,
Right.
which is signature to Malaysia. But it's just that when you use the uncle and when you do use the auntie,
Yeah,
the one
that's
in the younger group
Right.
might just catch up fast.
Now, you know, with all the education setting in, it's kind of ringing alarm bells. Like, you know,
Exactly.
if a young kid came and called you uncle, you'd be like, hey, my name's Navin. Like, I don't know, but things are changing. So how can we then help the elderly in our communities? You know, I mean, if you look at the larger spectrum of elderly within communities, how can we help them? Suhaila?
Okay, so what we would like to do, this is like a wish list, and we are really advocate for that. For all the elderly community that we have in our community, we would like to encourage them, get them engaged with the activity that we're doing, how we have a daycare for children. We would like to have a daycare for all these people so that they have a center where they can come, they can share their experience, they can do activities, that kind of thing.
As we discussed on the first topic, we talked about the football field and day one. You mentioned it.
Right.
So just to follow on, that's exactly, now it's lost. You need to put it back.
So they need to have a place to congregate and to meet people of their own vintage, so to speak. I like using that word vintage a lot.
I think it's vintage
sort of
is much better.
Yeah, it's sort of a verbal tick for me. Now, Doc, let's talk about if you have a parent with dementia at home, how do you deal with this?
See, dementia, it's very interesting. We need to change, not the person who's having dementia. We need to start listening to them, not from the ears, but from the eyes and from the heart. We shouldn't you know what happens in dementia, you lose the short-term memory. So you need to not ask them, what did you have for lunch? Have you done this? Because that will kind of confuse them further, because they'll be worried that, you know, they can't remember. So you need to change their attention, and you need to give them a lot of attention and work around whichever, and do not disagree. Because if you disagree, it will just make things worse, because they feel that, you know, they feel more, how do I say it, more lost, and more errors are coming out of it. So dementia is something that we need to work around that. That's the main important thing. We need to change.
The thing is, because with them, with the dementia, they're always at a different place and different time. You know, when you like talk to them, they, you know, sometimes they can be like 40 years old. Sometimes they can be like even like 15 years old. They're like, oh, okay, I have to go back now because someone is waiting for me. This is my personal experience with our patients that we have.
Yes.
You know, they're like, oh, I have to go now because my dad is waiting for me. They don't allow me to come here. They don't allow me to hang around with boys and things like that.
Right.
So you have to like, it's very sad, but then you cannot contradict with that because, you know, the trust that you build with them, you know, the connection that you have with them, you're just going to break it. You're like, oh, okay, your dad is there? Oh, okay, fine. I mean, where is working? What's his name? You know, you have to like kind of play along.
Right. Hold that thought. We're going to take a short break. And when we come back, we're going to delve a little bit more into care in aging and elderly care management right here on Medical Today. Stay with us. We'll be back just after a short break.
I have a vision correction number, but I'm more than a number. When I'm not enjoying my little sunshine, I'm enjoying my city's modern architecture. My S-Law lenses go beyond my correction. Their Creasel technology shields my eyes from reflections, scratches and smudges for optimal clarity. I'm more than a number. I'm a crystal clear catcher of the perfect image.
See more, do more. Essilor. Ask your eye care expert for advice.
I have a vision correction number, but I'm more than a number. When I'm not sharing ideas with my colleagues, I'm defending my kingdom on the back of a dragon. My EyeZen lenses go beyond my correction. They keep my eyes relaxed to stay focused and protect me from harmful blue light. I'm more than a number. I'm the never tired dragon eye. EyeZen.
Ask your eye care professional. See more, do more. Essilor.
Hello and welcome back to Medical Today. In the studio with me we have Suhaila, Mohamed, Kassim and Dr. Navindra, Nageswaran, both from Global Doctors, joining us to talk about aging and elderly care management. We talked quite a bit about it already, but let's take a look at managing loneliness, like Dr. Navin, maybe you can walk us through this,
Walk you through a little bit of loneliness. Okay, basically, they're at home. They've got no more their regular schedules and timings done. So we need to keep communicating with them. It's like a child. When you have a child, we actually pick up the phone and call and speak to them where you are and what you're doing. You have to do that. You have to keep them engaged. Secondly, I think you got to take them out. Many people find it a bit difficult if they have a walking sticks or mobility becomes a problem, then they don't walk. So you need them. You need to take them out. You need to engage. Take them into the community, like what we were discussing. A center where they can engage with neighbors and friends.
Okay, but how do you do it, when, especially those who are lonely, they start getting into conversations that spiral downwards. Oh, my life is so hard, my back's aching, but how do you get them out of it?
It's like this. If 5 people come and tell them my back is back and my hand is out and my eyes are not working, it'll be everybody in the same tune. It's like everyone is in AM mode.
Right.
And suddenly, out of the 5, you'll have one FM. They'll come and say, I'm perfectly good, I'm very happy, and I'm all excited. Then the others will look at it, and that's how you need to engage. When we are in the family, when you're all in the house, everybody is in the same mode. If they are depressed, we just leave them. We can tell them don't, like, I say, don't parent the parent, right? So we can only tell. But if you engage them in the outside community, it makes a big difference. And you pull them out of the loneliness zone, and that will lead you to depression.
But okay, how do we know if we're teetering on loneliness or falling into depression?
Depression, you will feel totally unhappy, and it will be sadness, tears, they'll cry very fast, and that will lead to you need a bit of psychiatric and help and all that. But that depression can be cut off if everybody at home plays a role in the loneliness.
Right.
Like what I just mentioned.
But I think that the thing that's running through my head now is that the GP you go and see has to be able to evaluate this and call it for what it is.
Correct.
If it's loneliness or depression, should they be able to walk into the right?
They need to spend time with the patient. The time they have, the GP needs to spend enough time. Information like this cannot be gathered like when you have a cough and a cold.
Right.
You can just examine and treat because it's the same set. But when it comes to loneliness, depression, you need to build the trust with the patient. You need to build a bond, and that takes you at least 15 minutes to half an hour. You can't do it in 10 minutes.
Right. Suhaila, coming to you now, let's talk about the best traits for a good caregiver. If I want to be a caregiver, if I'm training myself to be a caregiver, what are the best traits a caregiver should look for in his or herself?
Okay, so first of all, what you have to understand their need, because every individual, they have a special need, and then adults are not just an old adult. So basically they have a specific needs that they would need. So first of all, you have to be very attentive. You have to know what's going on with them. You have to assess their need. You have to be dependability, Yeah, you have to see what they can do, what they cannot do. You have to assess. When you do the full assessment from head to toe, you'll be able to know what is their capability, what their ability to do and all. So with this, you have to gather and then you can assist them. And you have to engage with them in a sense like you have to earn their trust. You have to be connected with them. So that is like all the important things, and you have to like, you have to be very compassionate with them. You have to be always respectful of them.
Some people say that you have to be trustworthy. What does that mean? Or how do you, I don't see it in this context. What, they need to be able to trust you?
They have to be able to trust you. See, if it's like, okay, I'm outsider, I'm a caregiver, or even their own family members, right? So I have a special need. So how do I, because everybody will always, they always assume this is what I need. At 8 o'clock, I must have my breakfast. At probably 11 o'clock, I have to have my tea. And then at 1 o'clock, why don't they ask me what I want, at what time I want to do, and what food I want to have, and what activity I want to do. So you have to speak to the person, you have to speak to the elder. Okay, come, let's do this together. Then you will indirectly you motivate them to do. Is that there's no point for you to have so many programs lined up, like you have a schedule, like how the timetable is and all. But if you don't get the trust from them, because they must know you are here to help them. You are not here to boss them around. They are not, that kind of thing.
So it's very good that she brings up all these points. They're all very pertinent points, I must say. But there's one red flag standing out now. You have to be compassionate, you have to be attentive, dependable, trustworthy, and they need to buy into that.
Yes.
Now here's the other thing. When do you know as a caregiver that you're being bullied?
We always get bullied, trust me that.
The caregiver always gets bullied. I mean, but if the caregiver looks at it from a different perspective, that you are giving care to someone, then you won't feel it. If a child did this to you, and the child does bully you, if I don't want anything, they'll bang, break the glass, and you do that.
Yeah,
you actually tolerate the child's tantrum, you tolerate it. But why is it when you come to an adult, we always say it's a tantrum? You can work around it. The other thing that was also mentioned is caregivers must know how to identify risk.
Right.
You came and learned CPR. There are steps that you need to. You know what to do when someone collapses. But here, you need to also look at the environment and look at the risk. When you take them out for a dinner, you take them out for a meal, you look at nearest toilet because there's incontinence problem. You've got to make sure that the steps are clear so when they walk, they won't fall. All these are caregivers' responsibility, and needs a lot of teaching.
Yeah, and you have to adapt very creatively. Like you said, being bullied by them, you have to adapt creatively. For you to get them to finish their food. You have to be creatively in that particular situation. You have to adapt and make sure they follow what you ask to do at the same time.
It's a cycle. Child, adult, and then super adult.
Right.
Super adult.
Super adult. I would like to be known as that as I grow older. I think I can live with that. Super adult.
We have a prime minister, super adult.
Super adult, yeah.
Yes.
Apparently, he takes less sick days off than the rest of us.
Correct, exactly.
Well done, Thun.
Well done, Thun.
That's very true.
Yeah.
It is.
But having said that, physical activity is very important. Exercise. And a lot of them believe that they're on meds and, oh, I'm too weak to exercise. Now that motivation behind getting them to do that little bit of exercise, how do we instill that?
Okay. Once we build their trust, we are already stay connected with them. We have their engagement. We have to kind of do it very slowly. When we say exercise, it's not like going to the gym and do exercise and all the heavy liftings and things like that. While they're watching TV, while they're doing something, they're talking to us, gossiping. Because when it comes to elderly people, they have lots of memories about the past years.
Right.
So the way that you have to tackle with them is like, hey, last time di sekolah kat mana? Who's your friend?
Right.
While doing that, give them a small dumbbell or give them a stress ball. Ask them because
and
it's
you
not.
have to add mobility.
Yeah,
You have to teach them how to tell them that exercise is important for their well-being. If they don't just stay at home, their hands will get stiffer, their legs will get stiffer. So a lot of education you're actually doing the same thing for your kid. You force them to go and play.
It's the same thing.
It's the same thing,
but
in a
you need to work
perspective.
around the sensibilities,
Yes,
because
correct.
they're super adults.
Yeah. So that's why we say adopt creatively. You know, if like they don't want to do at a particular time, but find a way how to do it with them while talking. You know, because if there's a stairs, it's like, oh, I left something upstairs. Come, let's go slowly and pick it up. You know?
Right. Okay, we're running out of time. Very quickly, Doctor, how do you want to wrap this up? Suhaila, thank you very much for taking time off to be with us today. Doc, we've got about 40 seconds left.
Okay, in simple, we are here because of them, and they took care of us. Today, it's our responsibility to take care of them, so the journey moves on.
Well, with that, we'd like to thank the both of you. Dr. Navin, it's always a pleasure to have you here.
Thank you.
Suhaila, great to have you here to give us insights on working with super adults. Remember, they're no different than working with kids, but there are different sensibilities that you have to work around. On that note, I would like to thank once again Dr. Navin and also Suhaila from Global Doctors for joining us right here on the 5th episode of Medical Today to delve into aging and well-being. Stay with us. We'll take a short break and come right back.
I have a vision correction number, but I'm more than a number. When I'm not teaching courses, I'm taking steeper grades and tight corners. My SLR lenses go beyond my correction. They make my vision as sharp as my reflexes to capture every detail from near to far at any speed. I'm more than a number. I'm a rapidly focusing champion of courses.
See more, do more. Essilor. Ask your eye care expert for advice.
I have a vision correction number, but I'm more than a number. When I'm not enjoying my little sunshine, I'm enjoying my city's modern architecture. My Essilor lenses go beyond my correction. Their creasel technology shields my eyes from reflections, scratches and smudges for optimal clarity. I'm more than a number. I'm a crystal clear catcher of the perfect image.
See more, do more. Essilor. Ask your eye care expert for advice.
Hello, and thank you very much for staying with us right here on this edition of Medical Today. I'm Jared Ratnam, and just now, or in the last segment, we did speak to Suhaila Kassim and Dr. Navindra Nageswaran, weighing in on aging and elderly care management. They're from Global Doctors. They come in every week to give us an insight on aging and well-being. More on that next week, but for now, let's take a look at the tummy, or the stomach as we know it. Digestive disorders and gastrointestinal diseases is the topic we're delving into today. We have Dr. T Ruben Raj, who's a resident consultant. He's also a physician, an internal medicine specialist. He's a gastroenterologist and a hepatologist from Makota Medical Center, Malacca. And he talks once again about digestive disorders and gastrointestinal diseases. Let's take a look at that interview done by Nurata Amin.
Diseases of the digestive system. According to the Ministry of Health, digestive system diseases are recognized as one of the main principal causes of death in hospitals. Unfortunately, we always do not pay attention to our digestive system. It is important to ensure that the entire digestive system is in good shape in order to achieve optimal digestive health and to avoid gastrointestinal diseases.
Thanks for being with us on Medical Today, Dr. Ruben.
You're welcome. Thank you.
So, what are gastrointestinal disorders and why are Malaysians prone to this disease?
So gastrointestinal disorders are basically diseases that affect our GI tract. So our GI tract, if you have a look here, is made up of our food pipe, the esophagus, followed by the stomach, which then goes on to form the small intestine. This joins up and forms the large intestine. So all this is called the GI tract. So diseases that affect the GI tract are called digestive diseases. This also includes the accessory organs of digestion such as the liver, the gallbladder, and the pancreas. In Malaysia, we do have quite a high incidence of digestive diseases. A lot of these diseases is closely related to our lifestyle. And in Malaysia, our lifestyle is very closely related to our food. Okay? And we have very tasty food, but unfortunately, most of our food is not very healthy. Okay? A lot of our food is fried, it's a high salt content, it's a high fat content. And definitely high salt content has been shown to increase the risk of colon cancer incidence. Okay? Furthermore, our lifestyle in Malaysia is not particularly healthy either. We often miss meals, we have meals late. It's not unusual for us to see restaurants full at about 10 or 11 o'clock at night. As a nation, we don't really exercise much either. You know, we all need to be doing at least about 30 minutes of moderate activity, exercise a day, otherwise about 120 minutes of vigorous activity a week. And most of us, including myself, are unable to achieve this. So all this, and of course there's some genetic predisposition as well, all this predisposes us to lots of digestive diseases.
Right. So following to that, in normal circumstances, when we have like some sort of discomfort, pain or uneasiness in our stomach, we usually think it is probably either gastric, wind or stomach ache. But how do we differentiate them, doctor?
Yeah, so that's a very good question. So that depends on quite a few things. You know, all of us will experience some sort of abdominal discomfort at some stage, and you can't be running to the doctor every time you have a stomach ache. Okay? And unfortunately, it can be quite difficult to differentiate between a serious symptom and a very trivial symptoms. It's not uncommon for us to see patients, particularly elderly patients, who come here and they've been having some stomach pain for about a couple of months. They've been brushing it off, and when we do our tests, finally we find out they actually have a serious disease. So I would say that any vague, mild symptoms such as abdominal pain or bloatedness that resolves within a day or two is probably not very serious. But if you do experience a very severe symptom, something that does not resolve within 2 days, then I think it's warranted to visit a doctor.
Right. Okay. Since you touched a lot on the symptoms, right? What are the most common symptoms and signs of gastrointestinal disorders? Basically, the red flag symptoms and signs.
Okay, so there's a group of symptoms that we consider what's called red flag symptoms or alarm symptoms, and these are very important symptoms that require an urgent attendance to a doctor and possibly more tests done. Okay, these include any unintentional weight loss. This is quite a sinister symptom.
So it affects the
Yes, affects appetite as well. And also any difficulty swallowing, because this is an indication that there might be some difficulty or some blockage in our food pipe, the esophagus. Any evidence of bleeding, whether it's in our vomitus or whether it's in our stools. Blood in the stools can appear as either bright red or sometimes dark red or even black, depending where's the source of the bleeding. The lower down the bleeding, the brighter the colors, whereas if you have bleeding in the stomach, by the time it reaches your stools, it's often black in color. Any change in our bowel habits also warrants a visit to the doctor. And we all have different bowel habits. Some of us go to the toilet every day, some people twice a day, some people every 2 days. And what we're looking for is actually a change from that norm. Okay? For example, if a person goes to the toilet every 2 days, and suddenly over the last month or so they find they're having to go every day, then this is a change of bowel habit and they should see a doctor. And another symptom is also this sensation of incomplete evacuation after bowel motion. That's also quite a sinister symptom.
That's quite the common uneasiness that we always feel.
The incomplete evacuation is more further down. It's like after you've had a bowel motion, but then you still feel like something there, although there isn't. So that's an indication there might be some swelling further down.
Okay, so doctor, those are the signs. But what are the some gastrointestinal problems?
Yeah, so there's a whole host of gastrointestinal problems that we see in our practice. Some of the common ones include what's called gastroesophageal reflux disease. This is where the acid from the stomach comes back up the food pipe, and it causes patients to have this burning sensation. It can be quite uncomfortable and affects their sleep pattern even. Otherwise, patients often experience what's called gastritis, which is a discomfort or pain in the upper abdomen over a long period of time. Sometimes they can even develop ulcers in the stomach. So those are diseases involving what's called the upper GI tract, which is the stomach and higher up. We also have our large bowel, which can have lots of problems as well. One of the biggest problems and one of the biggest worry for any patient and also any doctor is bowel cancer. And in elderly patients with any GI symptoms, that's the first thing that we look for to make sure that they are clear of.
That is for people who practice wrong diet, like not eating on time, where it's supposed to be because of the acid. They actually come out at a certain consistent time, right?
That's right. So that's a few reasons for that. One is our diet. If we eat late, then the acid isn't neutralized in the stomach. The stomach naturally excretes this acid in preparation for a meal, but if you don't eat something, then the acid is left there and it comes back up. Some people also have a natural disturbance between their food pipe and their stomach, where the valve doesn't work very well.
So how do you assess a patient with gastrointestinal problems, doctor?
Yeah, so the assessment of a patient firstly involves seeing the patient, taking a history from the patient, assessing their symptoms, when did their symptoms commence, and what's the pattern of their symptoms, followed by a general examination. Sometimes on examination we may be able to ascertain the diagnosis. We may feel a lump or a swelling somewhere in their abdomen or on their body. Okay. Following up from this, we usually do some blood tests. Okay. What we usually look at is the full blood count, we look at their whether their blood counts are low, we do some liver tests, some kidney tests, okay? And then there are more specific tests to look at the gastrointestinal system. One of this is an ultrasound scan. What we often do for our patients is scopes. Okay? Many patients who have gastric problems require scopes done.
Okay, so those are the tests that you do. And how about the screening procedures for bowel cancer?
Yeah,
how do you do it?
So this is very important in Malaysia. We need to screen for diseases. So a screening procedure is basically a procedure, any procedure that is done before a patient has symptoms. Okay? We are trying to prevent the occurrence of cancer. We're not trying to pick up cancer and then treat it.
So early detection.
Early detection and preventing from cancer happening in the first place. Okay. Many countries advocate screening for bowel cancer. This involves either doing a stool test or doing endoscopic procedures, which is a colonoscopy, which is where we pass an endoscope through the back passage, into the back passage, and have a look at the large bowel. Okay. And any patient who's above the age of 50 or sometimes above the age of 45, whether they have symptoms or not, require to have a colonoscopy at least once.
All right. So who are other people who need actually screening tests for bowel cancer?
Yeah.
The ages, probably.
Probably, yeah. So it's mainly dependent on the age and also their personal history.
Usually how old?
So the evidence suggests that we should definitely start at the age of 50, needs to have a colonoscopy. we may even advise it earlier, at the age of 45, because we're often seeing cancers early these days. Okay? But there's an exception to this rule. If they have a family history of cancer, say some close relative has been diagnosed with cancer, bowel cancer at the age of 40, then this person needs to have their scope done 10 years earlier than that.
All right, so maybe 30s.
30.
Okay. Okay. So how often should it be done after they've done it?
Yeah. So if you do it once and it's perfectly normal and there's no abnormal findings, the next one is only in 10 years' time. But if we do find what's called polyps, polyps are just a swelling in the mucosa of the bowel. Over a long period of time, some of these polyps can progress to become cancers. And during a screening colonoscopy or during a colonoscopy, we're able to remove this polyp. So if we do find polyps, depending on the size and the number of polyps, they may need their colonoscopy done earlier, from maybe 3 years or 5 years.
All right. So let's talk about the patients, of course, that you've been treated. So most of your patients, when they come to see you, right, what are the most common conditions and what do they usually share with you, doctor?
Yeah, so the vast majority of our patients complain of just this upper abdominal discomfort. A lot of it is described as angin or wind, and we have to kind of decipher exactly what does the patient mean by wind, because every patient has a different meaning actually to wind. Okay, so the vast majority of them complain of some upper abdominal pain, which is what we term as dyspepsia. And this is usually related to either gastroesophageal reflux disease or due to gastritis. And most of them will require further tests like ultrasound scans and scopes done. The other symptom that we often find is a change of bowel habit or lower abdominal pain, and this requires further tests done for the large bowel as well.
Right, okay. So let's move on to the next one, the EUS itself. Maybe you can get a bit deeper into it. The scope of endoscopic ultrasound, or EUS, has grown to include a wide range of indications, and it is now being incorporated as an integral part of everyday practice in the field of gastroenterology. Is this the future to treat gastrointestinal disease, doctor?
So an endoscopic procedure is basically where we pass an endoscope, which is a long scope with a camera and a light source at the end of it. Okay. We can pass it in through the mouth, and it goes down the food pipe to have a look at the stomach and small bowel. So this is where this is a regular scope where we are able to view the lining, the internal surface of the stomach and these structures. Okay. That's endoscopic procedure. An ultrasound is a procedure where a probe, an external probe, is placed on the abdomen, and using ultrasound waves, we're able to visualize the structures within the abdomen. Okay? A common ultrasound procedure is where pregnant women have their scans done to have a look at their baby, and that's an ultrasound procedure where you get this black and white image. So an EUS, or an endoscopic ultrasound, combines these two modalities. The specialized scope that we use for an EUS has an ultrasound probe at the tip of it. So when we pass that scope with the ultrasound probe, we are able to perform an ultrasound through the scope from inside. Okay? That allows us to visualize the layers of the stomach. And because of the ultrasound waves, it also allows us to visualize structures outside the GI tract. For example, lymph nodes, the liver, the gallbladder, the bile ducts, and also the pancreas, because all these structures are very closely related to the GI tract. They sit next to the stomach, next to the esophagus, and we're able to use ultrasound waves from inside through the scope and visualize the structures very clearly.
All right. So how effective is EUS compared to other procedures?
Yeah, so there are of course lots of procedures or lots of tests you can do in medicine to look at all these organs. Other tests include CT scans, MRI scans, external ultrasound. Okay? The advantage that the EUS has over some of these procedures is that we are scanning from inside, and we are often, the EUS scope is often right next to the organ that we are scanning. For example, if you're scanning the pancreas, the probe is sitting in the stomach here and having a very close approximation to the pancreas, and that gives us very clear views.
Right. So is this how EUS performed?
Yeah, so the EUS is performed very much similar to anyone who has a gastroscopy for gastric problems. Okay, the scope is similar. The patient is given a little bit of sedation. Scope is passed in through the mouth, and once we reach the area of interest, we're able to scan them and do what's necessary.
Right. How long does it take, Doctor?
So it can take, it's quite variable, okay, depending what we're looking for. Sometimes we're very focused, we go in, we look for it, we find it, and the procedure is done very quickly. Sometimes it's more difficult procedures can take long. So actually it varies anywhere from about 10 minutes to maybe an hour. There's a few types of procedures that we can do with the EUS. Okay? It can broadly be divided into either a diagnostic EUS or a therapeutic EUS. Okay? A diagnostic EUS is where we pass the scope down and we just have a look at the organs. We have a look at any swelling, we have a look at any collection, we have a look at the structures, and sometimes this gives us a diagnosis. A therapeutic procedure is where we pass the scope down and we do a procedure to relieve the discomfort or to confirm the diagnosis. This includes passing a small needle through the scope to take a sample, or passing a stent into a blocked area to relieve a blockage, or if there's a fluid collection somewhere near the stomach, we can also pass a stent in there to remove the fluid. Okay, so that basically divides the EUS into diagnostic and therapeutic roles.
Thank you, Dr. Ruben Raj,
Okay.
for being with us on Medical Today.
Okay, you're welcome.
I hope you enjoyed that little interview there. That was Dr. T Ruben Raj, a resident consultant, physician, internal medicine specialist. He's a gastroenterologist and a hepatologist from Makota Medical Center, and he spoke to our very lovely Nurata Amin about digestive disorders and also gastrointestinal diseases right here on Medical Today. We'll take a short break. We'll come back with a very interesting video for you right here on today's edition of Medical Today. Stay with us.
I have a vision correction number, but I'm more than a number. When I'm not sharing ideas with my colleagues, I'm defending my kingdom on the back of a dragon. My Eyezen lenses go beyond my correction. They keep my eyes relaxed to stay focused and protect me from harmful blue light. I'm more than a number. I'm the never-tired Dragon Eye, Eyezen.
Ask your eye care professional. See more, do more. Essilor.
I have a vision correction number, but I'm more than a number. When I'm not teaching courses, I'm taking steeper grades and tight corners. My SLR lenses go beyond my correction. They make my vision as sharp as my reflexes to capture every detail from near to far at any speed. I'm more than a number. I'm a rapidly focusing champion of courses.
See more, do more. Essilor. Ask your eye care expert for advice.
Welcome back to the final segment of Medical Today, episode 5 to be exacting. Well, every week we bring you a video, and this week yet again we have another video for you. And this video talks about accidents and incidents. We bring you different scenarios and how you can work with them. Today we're talking about something all of us have when we play games, whatever. We have a frozen shoulder. So we're going to take a look at what a frozen shoulder is all about and what we can do to alleviate the pain or the situation. Let's take a look at this video on frozen shoulders right here on Medical Today in our accidents and incidents segment. Take a look at this video.
So today I'm going to demonstrate some exercises that may be helpful for those who are having frozen shoulder. Basically, frozen shoulder have three phases, which are freezing, frozen and thawing. Patients that having frozen shoulder will have stiffness towards their shoulder joint that may limit their shoulder movement at every direction. So the purpose of this exercise is actually to increase the range of motion of the shoulder joint and improve the mobility of the shoulder joint itself. So the first exercise, we call it as pendulum exercise. So in this exercise, you just need a chair or anything that's stable enough for you to support yourself so that you can maintain your balance. Okay, so your strong hand, so for this patient, the affected hand is on the right side. So your strong hand needs to be on the chair while your affected hand needs to be in hanging position. So in this exercise, there are three movements which are upward, which are forward and backward, sideways, in and out, and also circular motion. So we start first with the first movement, which is forward and backward. So you need to move your body as well so that the movement can occur in your shoulder joint. Okay, so you can move your body forward and backward, forward and backward. Good. So we move on to the second movement, which is sideways. Sideways, in and out. You have to remember you have to move your body as well, in and out. So the last movement is circular motion. So for this circular motion, you may start first with a small circle, and as you feel comfortable with your shoulder joint, you can make the circle bigger. Yes, good. So for this exercise, you can repeat 10 times for each movement, and you can do 3 sets in a day. Okay, so before we proceed to the second exercise, let us move the chair. So for second exercise, we call it as stick exercise. You just need a stick for this exercise. Okay. In this exercise, there are 5 movements, which are upward, sideways, backward, internal rotation, and also external rotation. So you need to remember that your non-affected hand must be at the bottom of the stick, while your affected hand, which is your painful shoulder, need to be on the top of the stick. Okay, so the first movement is upward movement. So your strong hand need to push the stick upward. Yes, good. So hold it there for 15 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Relax. Good. So the second movement is sideways. So just move the stick to the sideways. Yes, good. Relax and hold it there from 1 to 15. Good. Relax. And the second movement is backward. Okay, move the stick backward and hold from 1 to 15. Good. Relax. And the next movement is external rotation. So for this movement, you need to remember, you need to make sure your arm must be close with your body throughout the movement. Okay. So move the stick sideways with your arm close with your body and hold from 1 to 15. Good. Relax. Okay. The last movement is internal rotation. So the bottom hand is the affected hand, which is the painful shoulder, and use the strong hand to lift up the stick so your affected hand can go up. Yes. Good. And hold from 1 to 15. Okay, relax. So that's it for our exercise. So it is advisable for you to consult with your doctor if the frozen shoulder persists. Thank you.
Hope you enjoyed that video, accidents and incidents, talking about frozen shoulder today. So the next time, if you're ever afflicted by a frozen shoulder, don't forget to use those tips. Of course, that video in accidents and incidents was brought to you by Makota Medical Center. In the meantime, if you do have any questions for us with regards to your health or anything at all you want to know about the world of medicine, please send us an email with your question. Send it to ask@medicaltoday.my. That's ask@medicaltoday.my, and we'll be more than happy to get you all the information and answers you need right here on Medical Today. Just to give you a heads up, in episode 6 next week, we will be looking at balloon cardioangioplasty. It sounds like a bunch of big words, but it's just something to do with the heart. It's a very simple procedure these days. Of course, there are technicalities surrounding it, so we'll have a subject matter expert coming into the studios to talk to you about balloon cardioangioplasty right here on Medical Today. You have a fantastic day ahead and a great week. I'm Jared Ratnam signing off for the Medical Today team. Bye-bye.